the December ICP meeting. It's lovely to see you all, and all Christmas jumpered up, which we'll come on to. Bit of housekeeping first, if I may. First of all, don't forget we're live streaming today, so to bear that in mind during the meeting. And also, could I ask you to be mindful of your use of the chat to avoid, if we can, separate discussions in the chat, please, because the chat's not accessible to all. So do put your hand up and try and come in. Well, I will get you in as quickly as I can when I see the hands up. Also, could I ask you to take care when muting to not mute all? So be careful with the mute buttons. And just if you are muting, make sure you're just muting yourselves. So let's go, before I do the welcome to the members and so on, let me just go straight to Susanna for the Christmas jumper intro and the further information on that, Susanna, and why we're doing it.
Okay, so morning everyone. This has become something of a tradition for the Suffolk and North East Essex ICS, that our December meeting usually falls on or around Christmas jumper day. So thank you to everyone who's wearing their Christmas jumpers. If you would like to make a donation to charity, as people do around Christmas jumper day, then my backdrop, which I could lean over so you can see it, has got some QR codes on it for some local charities, where there's a facility where you can donate very quickly and easily, and also Save the Children, of course, who have started Christmas jumper day. So what we're going to do is we're going to put that slide that's behind me up as the holding slide during the break, basically. And if you use the QR codes, it goes straight through to those. So yeah, there's Essex Community Foundation, Suffolk Community Foundations, their winter appeals, Home Start in Suffolk, and also the North East Essex Stronger Together programme as well as Save the Children.
Wonderful. Okay, thank you very much for that, Susanna, and thank you everybody in anticipation. So a big meeting today, and we've got the best 49 now, so we've got the best part of 50 people in this meeting. And as Susanna will talk to you about during the matters arising from the last meeting, there's been a membership refresh. So lots of new members today. Welcome to you all. Welcome to guests and speakers, of course. There's probably too many new members for me to actually go through and list them all without spending too much time on this item. But Sarah Muckle, if you're with us, Sarah, welcome from Essex. Lovely to have you here.
Yes, thank you. I'm here.
Good morning, Sarah. And welcome also to Lee Healy, Beth Mosley, Lucy Bayliss, who we've already talked to about your jumper, Lucy. So lovely to see you all. And I'm not trying to pick out everybody, but just some names I can see. So it's great to have you all here. Just by way of introduction, this is a great opportunity. This meeting is an opportunity for best part of, well, now 50 people to get together and talk. So please do come in whenever there's an issue of interest or an item you can contribute to. Your hand up is most welcome. There are a number of apologies. Susanna, do you want to just explain how we deal with apologies at this meeting?
So rather than listing apologies overall, I'll just pick out a couple. We've got a couple of adjustments on the agenda just to unforeseen circumstances, but there are some people here who are deputies to members, so it'd be really, really helpful if you could just, when you speak, if you could explain who you are, where you're from, and particularly if you're deputising for somebody as well, that would be helpful. Thank you.
Thank you, Susanna. There is one apology that I'll give, and that is on behalf of Ed Garrett. Now, some of you may be aware it is in the public domain, but Ed isn't with us today. He 90% of the time he is with us, but he isn't with us today because, unfortunately, Ed's father died on Monday just gone, as a complete shock and a surprise, an unexpected death. So, as you can imagine, this is a big impact for Ed and his family. So, I think, should we say, on behalf of all ICP members today, that we send best wishes to Ed and his family, and we have complete understanding and empathy and sympathy with the position that he's in. So, understandably, Ed isn't with us. Declarations of interest. You will note that the declarations of interest in the workbook that you've received as part of the paper pack has been updated. So actually, let me do an encouragement there. If you haven't yet registered your DOIs with the team to go into the workbook, would you kindly do that? That would be most helpful. But are there any declarations of interest or potential conflict of interest with any agenda item today other than what is in the register and of which we're aware? And John, did I see you lift your hand there?
No, you saw me scratch my nose.
Oh, did I? So I'm trying to spot the hands up. So I don't see any, in which case we'll say no declarations of interest or potential conflict of interest today with any agenda item other than those of which we're aware. In which case, let's then move on to minutes of the last meeting, the 11th of October. Great set of minutes there, I think. Are there any issues with regard to, let's take them on block rather than turning the pages. Are there any issues with regards to truth and accuracy that anybody would like to raise? Otherwise, again, I see no hands raised. Should we say that the committee today resolved to accept the draft minutes as presented as a true and accurate record of the last meeting? All agreed. Thank you very much. In which case, then, the matters arising, which are in the workbook that you've got, and they are for us to receive today. Before I go to Susanna for the specific item on the ICP Memorandum of Understanding and Terms of Reference, let me see if everybody is content with the matters arising update that is in the workbook. Any hands raised to disagree? We'll take that as agreed. And then, are there any other matters arising which you think should have been captured that we haven't captured in the workbook? And I don't see any hands raised, so we'll take it as complete. In which case, Susanna, can I go to you, please, for the MOU and the tour update?
Okay, so this is simply to ask the committee to approve a revised version of the Memorandum of Understanding in terms of reference for the Integrated Care Partnership Committee. The revision to the terms of reference specifically relates to the recent review that we've undertaken of membership. So everybody should be aware that I've written out to members individually with a copy of the terms of reference and asked to kind of just review and check that we've got the membership and the interests that each member represents correct. I've also been doing a little bit of administration in terms of being clear about where people have a regular deputy or if there's an admin contact that we need to be in contact with as well, and also been reminding people around their declarations of interest. So thank you to everybody for your responses to that. So in short, Chair, the main revision to the terms of reference is a revised structure for the membership of the committee, with a couple of minor changes to it. It stands our committee membership at 70, and you can see that reflected in the meeting today.
Wonderful. Any comment? Thank you, Susanna. Any comments or points to raise on the revised MOU and terms of reference as presented? Otherwise, we're asked to receive and approve today and note that the next revision will be completed for December 2025. Is everybody content with approval and revisiting by the end of 2025? Agreed. Lovely. Thank you very much, everybody. Thank you, Susanna. Is there anything that you want to add any more, Susanna, or I'll move us on to the next item? I'll move us on.
That's fine, thank you.
Thank you, Susanna. Now, Howard, you've kindly deputising for Ed today and Ed's updates. So thank you very much for finding the time. I know that life has become exceptionally busy of late for a bunch of reasons, but your time is much appreciated. So I'm going to come to you for the ICB update, please.
Many thanks, Chair. So good morning, everybody. I'm Howard. For those of you who don't know me, I'm Howard Martin. I'm the ICB Director of Finance and deputising for Ed Garrett today. And my sincere apologies for missing the memo on the Christmas jumper. Do apologise, Susanna, but I will be making a due contribution to the charities. By way of update, I guess first just to congratulate ESNEFT for the delivery of the Orthopaedic Centre. 300 jobs, and named after Dame Clara Marks, the first female president of the RCS and GMC, alongside the excellent work she did clinically across SNE. So it's fantastic news that facility has now opened. Can also report that the Newmarket Community Diagnostic Centre is due to be opening soon, and the business case for an equivalent facility in Ipswich, I think, has now been approved as well. So we're making progress on those fronts. A new hub for the ambulance service in Bury St Edmunds has opened, housing 33 ambulances. And our system has the best performance for productivity in the east of England, and this has mainly been delivered at ESNEFT, with also increases seen at West Suffolk Foundation Trust. So we seem to be well placed on the productivity, the increasing focus on productivity as we go into next year. Thinking ahead to next year, we are of course grateful for the government to the increases in resources for the health service, and as I'm sure you'll appreciate, we're also very interested in the national insurance employers' contribution and the concerns raised by GPs, the voluntary sector, etc. There's been a lot of coverage on the arrangements for the NHS and the shape of the government's proposals for the NHS long-term plan. And we will assume that this will start to become much clearer over the new year. And at this point, we're still waiting for final allocations and guidance pertaining to 25-26 as well. But we're very mindful of those additional pressures that have come out. I also wanted to brief you all on the sustainability review that we will be commencing within the new year. That will be looking to conclude in April. The background to this is that West Suffolk Foundation Trust are currently overspending and also have a new hospital being planned, which will of course need to be affordable. We therefore want to carry out a review for a strategic solution on how the acute sector in Suffolk and North East Essex can live within its financial means in the future, and also of course better support our overarching strategy to develop the future shift agenda that I know is core to our ambitions, and also those set out by the new government, and of course is on the agenda today. In terms of the in-year financial position, we aim to deliver a balanced position for 2024-25. This will trigger a £30 million incentive payment from NHS England, and we might be one of the few systems in England to actually achieve this. However, in order to achieve that, we are having to make some very challenging decisions, including currently holding back some ICB investments in the last 4 months of this financial year to compensate for the overspend in the acute sector. We understand that this is frustrating for many stakeholders, but there is a clear rationale, I think, for doing so. And we also really do need to prepare ourselves for what we think will be a challenging 2025-26 settlement. I'll stop there. Hopefully that was helpful, and of course happy to take any questions.
Howard, that's great, thank you, and really useful update, and I'm sure that the committee as a whole thanks ESNEFT and West Suffolk particularly for that productivity increase and performance, which actually is a bit of a national standout, isn't it, from an achievement point of view. So thank you all. The thing is, Howard, I suspect you might want to comment on this. It's actually not the end of the game, is it? It's the beginning of a journey, really, there in productivity. Do you think?
Yeah, 100%, absolutely. I think we're starting from a good place, but there's a long way to go. Yeah, absolutely. It's a continuous journey, and we're currently working on how we can support the trust with better information, ensuring that there's better benchmarking between various providers in the East of England, and of course there's national programmes around this as well. So yeah, I don't expect that agenda to disappear anytime soon.
No. Sorry, go on, carry on. Yeah, you done? Yeah. Okay, thank you. I don't see any. Oh, John, yes, I see your hand now.
No, thanks. And I didn't know about Ed, so thanks very much for telling me, and sympathies to him. If Ed had been here, I might have been asking how much his plans on the financial front are going to be jeopardised by the tidal wave of flu and norovirus cases. Nick Hume was on the radio this morning talking about probable further cancellations of operations because they've got people in corridors, and what their feelings are about this continuing. It does seem to be a really tricky position the hospitals are in now, and whether there's anything more we can do to try to do more work on the intermediate care front to stop the hospital admissions.
Thank you for that, John. That's a really good question. And the last I heard, I might not be completely up to date, but last I heard, bed occupancy at Colchester was 105% because of the pressures of the so-called pandemic. But I see that Andrew's raised his hand, and Andrew would. Oh, sorry, Howard. Did you want to come in there? Are you?
No. I was just going to suggest perhaps Andrew's better placed than I am to comment on that. Yeah.
Okay, thank you. Yes, let's go to Andrew. Over to you, Andrew.
Yeah, I mean, we can't diminish the potential impact of things like norovirus, and there is a new strain of norovirus circulating, which is causing us some concern. So maintaining really good hygiene measures is going to be vital to getting through the winter, particularly in hospitals, but also outside hospitals. However, although there's a bit more we could do in flu vaccination, we're doing actually very, very well on that. We're the best in the region and among the best in the country in over 75s for flu vaccination. And whilst there isn't room for complacency in that, I think that sets us off to a good start to get through the winter as well as anybody can. There is the usual inverse care law with vaccination, particularly flu and COVID vaccination, and people from less deprived communities are less likely to access that. I'm really keen to work with system partners on any ideas you've got to improve vaccination rates in deprived and less well-served communities if possible.
Yes, very.
Well,
yes, John, come in.
I mean, it's probably vaccination now is probably going to be too late to help the current situation. But any information we have, and I know my Director of Public Health on the call, that we can get about where the hotspots of low vaccination rates are, then we can focus on how we get to those particular groups and populations of people.
Thank you, John.
Yeah, just to, sorry to butt in, but just to say, you know, I agree with John there. If there's anything that I can do to work with you on that and, you know, work with NHS England as well, then happy to do that.
Sarah, thank you very much, and thank you for the point, John. I'm just going to hold Nicola for the moment, but go back to Andrew. Andrew, did you want to come back on the timing of vaccinations point?
Yeah, it is never too late to consider vaccination. Even in the acute phase of illness, vaccination can be helpful. So, you know, we often tail off a bit after Christmas because everybody's spread it around their families by Christmas time, but actually it's never too late to think about flu vaccination.
That's a very good point, Andrew, because
I sit corrected.
Yeah,
you're quite right.
Don't worry, John. Yeah, because February can still be tough if we're not careful, can't it? So, yeah, absolutely. Let me go to Nicola, and then Kirsten, I'll come to you. So, Nicola?
Yeah, certainly. Thank you, Chair. I was going to say the same, never too late for vaccination. So please do and encourage people. And I was just reflecting on the fact that we've got the great and the good here. I feel kind of very privileged always to be part of this meeting. And I don't know about anybody else, but friends and families often look to me for kind of advice about what they should do in situations. And we do have quite a lot of power to influence around that, whether we're talking to the public, service users, or indeed family and friends. And there is something that we need to get over, which is around that hospital is often not the safest place for people, and there is still, we see on a daily basis, people brought into hospital, attending hospital, where it is not the safest place. They then get sucked in because they are ill and elderly often, and they get a whole range of tests and end up sucked into the system. We take some responsibility for that as acute and community providers, but I suppose I'm really reaching out to every part of that system to support us in that message. It can require being quite brave with people and having quite challenging conversations sometimes, but genuinely an awful lot of frail elderly people are much better staying out of hospital, and particularly at the moment when we do have infections, and we've certainly seen the same as the east part of the system. So in West Suffolk we've also seen more flu than we were anticipating at this time of year.
Yeah, thank you, Nicola. Well articulated, and as we've said so many times, you only want to be there if you really got to be there. Absolutely. Yeah, and that's true all the time as well, isn't it? But particularly now. Thank you for that, Nicola. And Susanna, perhaps we can, no need to respond to this in any detail, but perhaps we can take that request, shall we say, for messaging that Nicola has articulated and take that forward in an appropriate way, however you think that can be best done from an ICP perspective. Thank you very much. Let's take that as agreed as an action. Thanks, Susanna. Kirsten, over to you.
Thanks, Will, and thank you, Howard, for the update on the finances. You mentioned something about 25-26 being particularly difficult, especially if we don't get the overspend under control. And I was wondering when we're going to know some more detail about what the impacts might be. We've got on the agenda today 3 people talking about the impacts of the budget, and from the voluntary sector perspective, we'll hear about that. But, you know, there are a lot of different things going on at the moment that impact the voluntary sector. And I know a lot of voluntary sector organisations have funding from the ICB. So it'd be really useful now when we're trying to set our budgets, bearing in mind all the variables that have happened over the last few months, to understand what that pressure might be as well. Do we have a time frame for that?
Thank you, Kirsten. Shall I come to you for that one, Howard?
So as you can imagine, Kirsten, that's a question that many of us are asking on a very frequent basis. But we have been promised that we will receive allocations and the detailed guidance before Christmas. So let's hope that's held true, because we'll very quickly have to turn the wheel, so to speak, on the money and the guidance, etc., and work through the implications. But yeah, we're hopeful before Christmas that we'll see the detail that we need to see.
Okay, wonderful. Thank you, Howard. Steve, and then I'll go to Anna. Steve?
Yeah, thanks, Will. Just a comment on the vaccination uptake. There has been a very successful social media being run about remember to get your vaccinations, winter flu and whatever. As we've just pointed out, it's not too late. And I'm sure that everyone who uses social media, I mean, we've got, what, 50 odd people in here now, can spread that message, because people become complacent. The first couple of weeks, everyone rushes out to get their vaccination, their winter fuel. Yeah. Yeah, I've got that on my brain at the moment. Yeah, their flu jab. It's vitally important that we keep the pressure on social media, because we reach more people quicker that way. Just a thought. Thanks, Will.
No, thanks, Steve. And let's take that as an action for all to do what we can to keep that that momentum going. Actually, I'll just hold you, Anna, if I may, because I see Andrew's hands come up again. So let me go back to you, Andrew.
Sorry, Anna. Something I should have said earlier, but you really triggered me into mentioning it, Steve, is that somewhere we really definitely need to improve is vaccination and health and care workers. All of us that work in frontline services need to be really pushing vaccination. Our flu vaccination rates in health and care workers is about 30%, and COVID vaccination about 15%, 15. Bear in mind, at the height of the pandemic, COVID vaccination rates amongst health and care workers was about 70%. So we know what can be done when people's minds are focused. And so a lot to be done to stop them spreading it, not just amongst their patients, but also their friends and family. So another practical example. Thanks.
Yeah. Thanks, Andrew. Good point. Well made. Anna, sorry for holding you. Over to you.
That's all right, Chair. Thank you. Good morning, everybody. I'm Anna Crisp. I'm a consultant in public health in Suffolk. I'm deputising for Stuart Keeble today. I was going to make the point Andrew's just made, actually, about workforce, but also to add another risk group to people's awareness, which is pregnant women. Again, our uptake rates in pregnancy are very, very low. It's hard because people are not necessarily pregnant for the right time of the year, if you see what I mean, but another really key group where our uptake rates are low. Our uptake rates, generally speaking, are pretty good, and we're pleased with that, but there are some groups where we need to do more. And just to echo the support offered by Sarah for Essex from the Suffolk Public Health team, Will, so any links that you want us to make, more than happy to follow that up. Thank you so much.
No, thank you, Anna. Good point as well. Well made, and thank you to you and Sarah again for their Suffolk and Essex public health contributions. It's great that we're so joined up. So thank you guys for that. Any more questions for Howard, or actually anybody from the ICB, to be fair? Otherwise, I'll move us on. That was a really useful update, Howard. Thank you, and provoked a very helpful discussion. All done? That's great. Thanks all. In which case, Susanna, I'm coming to you for the next item, which is future shift update, and it's all yours.
Hi, so good morning, everybody. Hopefully you've had an opportunity to access the link, which is both in the agenda, in the covering paper that I sent, and also I've written out quite widely in the system now to circulate this document, which is a vision document for Future Shift. So we've been talking about Future Shift for some time, and now have pulled together, as you'll see from the document, very wide contributions on this issue from across the system into a single document. Now, the reason for bringing this to the committee this morning is it's proposed as an extension that builds on our existing integrated care strategy. So just in case you're unfamiliar with the ICS integrated care strategy, the purpose of ICS integrated care strategies is to set the direction of the system across the area of the ICS, but covered by the ICP and the ICB, and it sets out how the NHS local authorities working with providers, voluntary community and social enterprise sector and other partners can deliver more joined up preventative and person-centred care for their population across the life course. So the strategy should present an opportunity to do things differently to before, such as reaching beyond traditional health and care services to consider the wider determinants of health, joining up health, social care and wider services, and taking an approach on health creation in addition to addressing deficits. Take a breath. So that's the kind of official kind of description of what an integrated care strategy is. And it has a close relationship to obviously the joint health and wellbeing strategies for both Essex and for Suffolk. And it is a really important document because both the NHS, local authorities and other partners have a duty to draw on it in terms of then developing their own plans. So, for example, the NHS Joint Forward Plan for the NHS Integrated Care Board. So that's why we're bringing the document to you this morning, is as a proposed addition to that strategy. Now, I recognise that the document is 94 pages long, so I have discovered one person this morning who promises me that they have read it cover to cover, but I'm not expecting that maybe everybody has done that. Something I was going to mention at the end is that some people have said to me that to help make the document more accessible, they would appreciate a printed version. So we are going to be printing some copies, not too many. I don't want to be papering the system with them, but we will be printing a few to make the document accessible to everybody. But at the beginning of the document, you may spot that we've included two things, both a 2-page executive summary of the document and also this at a glance double-page spread, which sort of just gives you an overview of the content that's in the document. So the document begins with the kind of guiding principles, which were the principles that really were in our original integrated care strategy, what we started out with, which is that we want to achieve this left shift of the population, and then it moves through why we need a future shift, how we can enable a future shift, and what we can do to enable a future shift. So what I'm going to do is to kind of walk you through that, but just before I do that, This is the short version of the whole document, because really you can make this as it's 94 pages long, but it really comes down to one simple thing, which is it's about how can we genuinely realise our vision of genuinely putting people at the heart of what we do, and trying to kind of break down, if you like, the complexity, and this morning's meeting is yet another sort of demonstration of just the sheer diversity and complexity of our system in a way that puts people at the heart of health and care. So that's Future Shift, the short version. I'm going to be quite brisk, because some of you might have heard some of this before, but I do know that everybody hasn't heard all of this before, so I will go through this. So very briefly, the concept that we began with, the left shift in health and care, people will have seen hopefully before, which is that these 5 principles around a left shift, which are to start with why, better outcomes for everyone. The left in a left shift is about prevention. It's about trying to enable more people to live well for longer. So we want to keep people to the left of this diagram. We want people who are healthy to remain healthy for as long as possible, and to slow their progression in terms of accumulating long-term conditions, becoming frail. And we certainly don't want people living in Suffolk North East Essex to die earlier than they should. Thinking differently about how care is provided, and trying to move more to primary care, neighbourhood health, but then also local communities and people-powered health and care. The importance around equality and equity, and also that culture of can-do health and care. So that's our kind of base kind of principles. And then we've talked a lot about kind of, why we need a future shift, and the document goes through that, and it talks about our changing world. It talks about the way our population is changing. It talks about the state of care. It does draw on, in particular, the content of the recent Darcy report, which of course summarised that. But we have given in the document some figures to give you kind of, what that looks like, if you like, in terms of the local kind of data. We've also drawn on the Marmot 10-year review, and also the report which came out from the King's Fund towards the end of last year as well. We've drawn on our local system learning here in Suffolk and North East Essex over time, and also it talks about that we need to kind of think about new opportunities around particularly science, medicine and technology. So that's the kind of why. And then we move on to the middle section, which is about how we can approach, if you like, making a change. So this 3 horizons framework that we've used, you need to look at this and remember there's a timeline going from left to right along the bottom of this. So this is about really how do we move on from our current business as usual, the way we work at the moment, our status quo, which arguably we can see from the pressures in our system is losing its fitness of purpose, towards actually introducing a more viable future, that left shift way of working that we want to see in the future. So we've used that as a way to frame our conversation, and the document goes through 5 principles for how we make that future shift. So the first of those, it sets out in quite some detail, a lengthy section that talks about leadership, how we lead and how we work together. But this now goes into more detail. It talks about the importance of collaboration and collective accountability, leading with candour, being brave and taking risks, the importance of psychological and cultural safety, compassionate leadership, and intuitive can-do leadership as well. So we can enable particularly people at the front line to feel empowered and able to take action and to make the system work in a better way. The second principle is about how care is delivered in a more viable future. So more local, holistic, seamless care, care led by people and communities, more technology-enabled self-managed care, the importance of workforce development and building trust with the population. So it does set out, it really key examples of what more technology-enabled self-managed care would look like. And thanks in particular to colleagues from Essex County Council for the work with their Caring Communities Commission at the moment, which is really helpful in terms of that, building trust with the local population. We've featured as a case study there. And then that third principle about how we invest our time and resources. Our time and resources are incredibly stretched at the moment. We've never been under more pressure. We've never had as much pressure on resources. So it's about, thinking about moving on from the status quo, investing in system working, It talks about how we approach things like risk and governance and regulation and making those more system-oriented things. That's on our agenda this morning, a bit later on today. It does talk about financial investment and the need to get financial control so that we can make good decisions about how we can invest in more preventative, community-based work. We can make that left shift. It talks about the way we approach commissioning transformation, and also, very importantly, what we measure as well, and the importance of not just measuring performance and going beyond that into the benefit that we collectively deliver for the population and obviously outcomes. And then the document talks about how we, how we need to approach, how we innovate, innovating based on around people. It's very tempting to look at lots of, technical solutions and new technology and treatments and so on, but people have got to be at the heart of innovation, and that's what good innovation is all about. So the document talks about new technology, new treatments, but it does raise in particular the importance of ethics and building ethics into that as a system, and also thinking about how we work with innovators as well. And then the fifth principle is this one about this progressive approach to system transformation. So remembering that we need to approach transformation by building the right foundations, recognising that often where we might be beginning to do things smarter, that's not the end of the matter, that actually that then gives us the potential to start to think about doing smarter things and gradually reimagining health and care. And so that framework, you'll see, is the one that we've used to summarise then each of the 6 sections which set out then what we think it looks like to deliver a future shift. So what we can do as a health and care system. So the 6 areas are: we can co-produce and co-deliver with people and communities, we can prevent ill health, inequalities and injustice, we can deliver more holistic neighbourhood-based care, we can make more use of technology innovation, we can learn from data, evidence, knowledge, intelligence, and we can make better use of our existing resources. So in brief, I'm not going to go through this in detail, but the first of these, we can co-produce and co-deliver in people and communities. We have set this out now in some detail, and we're very, very fortunate that we've got excellent work that's come from the University of Suffolk, particularly work led by Sue Conker in my team, that sets out, if you like, not just a kind of principle-based, this would be lovely to do it, actually talks about what that looks like in practice, and gives some clear examples and methodologies for how we can approach that. So the importance of integrated community care, insight and oversight, co-production, community-centred approaches, what co-delivery with people and communities looks like, and it raises the importance of us sort of grappling as a system with the issues of reward recognition, remuneration and communication. In terms of we can prevent ill health, inequalities and injustice, the document talks about all 3, so absolutely they all overlap, but prevention, inequalities, injustice. Obviously, we've been doing lots of very good work as a system already in these areas. So, for example, the recent work around uncomfortable truths does give us a framework, doesn't it? Of those 22 things, if you like, that we can do, and we're already, again, it's on the agenda this afternoon. We've just completed the first self-assessment looking at those. So the document focuses on that. And then in terms of delivering more holistic neighbourhood-based care, the document talks first and foremost about the importance of general practice. We're very, very fortunate that we've got the pilots now taking place in a number of our primary care networks that are trialling new approaches in terms of better sustainability in general practice. We've also made good progress in developing integrated neighbourhood teams, but the document does argue that that's a really good start, but perhaps we could go further with our integrated neighbourhood teams. It talks about, for example, as a case study, what's been done in the Netherlands and other places around the Buurtzorg model. Is that something that we might want to look at as a system? But then, in addition, in terms of more holistic neighbourhood-based care, the voluntary and community, faith and social enterprise sector are absolutely key to this. So it talks about the importance of the sector in there, and also going back to that issue about that progression framework, building the right foundations, because innovation with the voluntary community sector is not sustainable if it's not built on the right foundations of sustainable relationships, funding and procurement. It also talks about the importance and around residential and domiciliary care and the opportunities we've got there, who are very, very key in terms of local communities and so on. And then the opportunities we've got around allied health professionals and advanced practice. So one of the concepts in the Future Shift document is this one around untapped potential. And I have to say, across all of these different areas, these are areas where people are talking about, look, there's lots more we could do. There's more that we could deliver. There's more that we could that could be achieved in all of these sectors. And I think that's a really exciting opportunity. Then there's the issue about how we can make more use of technology and innovation. And I think we're really just at the start of beginning to explore what this could mean for us. So innovation, new technologies and artificial intelligence. The document does begin to go into that and sets out it does set out a framework around kind of innovation. It does talk about specifically what some of the opportunities around artificial intelligence might be as well. And then thinking about how we can learn from data, evidence, knowledge and intelligence. Obviously, the cornerstone for this for us has been integrated care records. That is a huge enabler. It's been the biggest enabler in terms of driving now our capability around population health management. And I would just say it like this. Now we've got that capability, we need to use it. We need to use that opportunity that we've got to really kind of look at, if you like, some of our kind of old problems in new ways. Learning from evidence and research, but also very importantly, learning when things go wrong as well. So all of those are opportunities for learning. And there is something for us, I think there's a challenge for us about how do we actually get that learning into the system. As I said, how do we use that? And then last but not least, how can we make better use of our existing resources? So absolutely in terms of our role as anchor organisations. Again, that's on the agenda this morning, but also by simplifying our system. And then where can we do it once, do it well and do it together? So one really good example of this is that we've got huge resources in our back office functions and our big partners in the system. And then we've got lots of partners who are struggling at the moment. We're going to hear later on from sectors who are really up against it in terms of doing really some of the real basics. Where can we unlock resources that might be in some sector partners, if you like, in some parts of the system, and make some of those resources maybe available elsewhere? How do we educate our workforce for this future? Because our workforce are our biggest asset, our biggest resource. And then last but not least, we need to be future facing, thinking about environmental sustainability. So it talks about that too. So that's a quick whiz through the document. And as I said at the beginning, Future Shift is proposed as an extension to our ICS integrated care strategy. And as an ICS, we have always been very clear that we need to devolve decision making to those best placed to make changes and enable leaders to manage complexity at a local level. So one of the things I just want to point out is that the Future Shift document deliberately does not contain a detailed action plan for the system. It doesn't suggest that action has to be taken on absolutely everything, everywhere, all at once. And it's deliberately not overly prescriptive about what individual organisations should do. And that's because, if you like, instead it does something a little bit more powerful. It sets now a powerful set of principles that we can hold one another collectively accountable for, now reflecting in all the very, many and very necessary different strategies and plans that sit within our individual organisations, within our alliances, within other collaborative forums. If we can make these the golden threads that run through everything we do, then we're all aligned, pointing in the same direction. So lastly, in terms of next steps, we've brought the document to you. This is the committee. The ICP is responsible for setting that integrated care strategy. So that's why it's come to the committee for approval this morning. A suggestion that's been made to me very regularly is we need to share this nationally. There's a big debate going on nationally, which sounds very similar, doesn't it? The DARSI 3 shifts are very, very similar to our Future Shift conversation. So we can make this a contribution, perhaps alongside other things, to that current government engagement around Change NHS. But for me, I think what's important about Future Shift is it goes beyond the NHS. It talks about all partners in the integrated care system. Absolutely, there's lots, we're having the conversation today, but we're talking about the future shift in so many different settings at the moment. So in our health and wellbeing boards in both Essex and in Suffolk, and then obviously at the ICB board and People Committee, Anchors Programme Board, and so on, and some of our individual organisational boards as well. So I said, if it's going to be the golden thread that runs through everything, then we need to have those conversations. Already begun talking about how we can join up, for example, our NHS Joint Forward Plan and our ICB clinical strategy to future shift, so that they're part of that delivery. And then for next year, these are some of the ideas about some of the things that we might aim to bring people together around. So something around system culture and leadership, something around our untapped potential in our voluntary sector, social care providers, allied health professionals, and so on. A real focus on technology and innovation, perhaps with some new partners, some new innovators, asking them to work with us about the potential there for the future. And that all-important focus around untapped potential in our people and communities as well. But that it doesn't stop there. At the moment, I've got a number of other conversations around general practice, the voluntary community sector, people and communities. This, I hope, is a start, if you like, not a kind of end of a piece of work on Future Shift. I hope it's just a milestone in terms of where we need to go next. Thank you.
Susanna, thank you very much, and I think we can probably assure you, on behalf of everybody here, that this is definitely not the end of the game, because this game is never going to end. So thank you very much for that work in progress so far. Just while people are thinking through their questions, a couple of points from me, if I may. You know the point, I know who you're referring to, by the way, who's read all the 94 pages, but might it be helpful to produce an easy read version, do you think, if we could do that? And I'm wondering whether perhaps Andy or one of our Health Watch colleagues might also help with that process, do you think?
Partners in the system who I think can help us with that. Yeah. And also the other thing, Will, is that I think the different audiences, they want to draw out slightly different things as well. But certainly once the document's approved, we definitely want to make it accessible in as many ways as we can.
Wonderful. Okay, well, let's take that as an action, assuming we approve it today. And then just before, I see the hands are coming up now. So just before I go to them, though, assuming we do approve this today, your suggestion about taking it forward into the NHS submission, might that be something that the ICP committee might want sent on the three co-chairs, unless my fellow co-chairs disagree? Perhaps we could write a co-chair's note supporting on behalf of the ICP and covering the submission. Would that work for you, Susanna, as well? So unless Steve's a thumbs up from Steve, do I see a thumbs up from you, John, as well on that one? No, don't see it yet, but assuming John doesn't, I see he's nodding. So assuming John doesn't agree, let's take that as an action as well, assuming we approve, Susanna. So with that, let me go through the list that's before me. Jane, I'll come to you first.
Thanks, Will. Yes, Susanna, I've said this before. I think it's a brilliant document. I particularly liked it because it's a strategy document, but you also suggest, how we can bring out untapped potential in the system. I particularly like the bit on pages 72 and 73. And the stuff about the allied health professionals, advanced practice. So, Susanna, I was hoping that you could actually send it to, obviously we're in 3 systems, to MSE and Herts and West. John and I were at MSE on, what day was it? Wednesday. And we were having a similar conversation. And I said to Emma there that she should have a good read of it. There's no point, having to reinvent the wheel all the time. But yeah.
So thank you, Jane.
Could I just come back on the back of Jane? I totally endorse what Jane said, Susanna. It is a superb document. Jane's done a really good study of it. It's turning it to a reality. The more we can engage with the other systems And then what I'd really like to do is get a process, which brings us to an Essex-wide meeting that we can start taking it forward together.
So thank you, Jane and John. We invited colleagues from not only both the other Essex systems, but also from Norfolk and Waveney to some of the meetings around Future Shift. And when I circulated the document on Friday, they were copied into that. So everybody who was invited to those meetings will have received it. However, I think you're absolutely right that we need to be proactive. And John, Future Shift, I think, is on the agenda for the Essex Health Wellbeing Board in January. And perhaps at that meeting we could agree kind of a way to work across the three systems around that. That would be really welcome if you could help us with that.
I'd be grateful if you could do some churning of the ground in advance of that. The more you've got people in a state of preparation well in advance will help.
Yeah. Thank you, Jane. Thank you, John. And Susanna was nodding to that, John. So all agreed. And thank you both. Let me go to Kirsten.
Thank you, Will. And thank you, Susanna, for the Future Shift paper. I mean, it's an amazing document. You have my full support. And I say that on behalf of the Voluntary Sector Assembly, which you attended earlier this week and you were able to present. And I think you got a very positive reception from that. We're really behind this and we think it should be part of the strategy. It's important for communities, it's important for people, and you know, the voluntary sector is very much part of delivering services and supporting people in their communities. What I would say, though, I heard the message from you just now about how we're going to really make this happen and action it. And those of us who sit on alliance committees, who are around the screen today, I think we need to take action as soon as possible to get this started. I'm kind of assuming we all agree that we're going to do this and it's part of the strategy, but I think we need to really crack on with this and take some ownership of it and get it started.
Thanks, Kirsten. I'll ask Susanna to respond to that. But Susanna, in your response, do you think we might, therefore, assuming this is all assuming approval, so let's assume that, Kirsten, as you articulated there. But shall we, assuming we do approve, Susanna, shall we ask the alliances to do exactly as Kirsten has said?
We'll do exactly that. So it's now over to all of, as I said in my slide, all those various mechanisms that we have to develop delivery plans to reflect Future Shift now in those delivery plans. So whether it's the joint forward plan for the ICB, whether it's the alliance plans that we've got, other plans, I've certainly had some conversations about some individual partner plans. Andrew and I've been talking about clinical strategy and so on. It's really about now weaving it through in all of those different settings. It's not for the ICP to set delivery plans for the system, but hopefully this does set a strong collective strategy that everybody can draw on.
Yeah, agreed. Thank you very much, Susanna. Lisa?
Thank you. Hi, I'm Lisa Andrews. I am deputising for Sharon Alexander, Chief Executive of CBS Tendering. Wanted to just echo what everyone said about what a great document is, but I will put my hand up because I haven't read all 94 pages. What I did do was have a review of it in advance of reading the papers for this meeting, and I was particularly struck with some of the case studies. And the one that struck me in particular was the MIND case study around their personality disorder project. And it's something that voluntary sector does a lot. We identify a need, we find a way to meet that need from our own funds and resources. It meets a sort of strategic need across the system, but it's unsustainable because nobody will fund those things long term. So how we turn what we do into business as usual, I can see it's clearly part of the document, but I'd love to, you know, to be able to really embed that in our systems. I think from the point that Kirsten made and others have made about it coming through alliances and at Alliance Committee, Sharon sits on the Alliance Committee, but as her deputy, I sit on the Alliance Operational Delivery Group, as a number of my colleagues around the table do. And I think that, again, you know, really sort of having sight of this document at that level, at that delivery level, so that people are really aware of that and can think about how we do that and bring this into business as usual when we find an innovative solution to a problem. I think that's really important for us to focus on. Thank you.
Thank you for that support, Lisa. Did you want to add anything, Susanna?
I was just going to say that what you're drawing attention to is how important the hows are. So that progression framework, because it's all very well to have something to be, you know, do smarter things or doing things more smartly and so on. But if you haven't got those foundations, is what you're pointing out, then it falls by the wayside. And we've talked about that so many times. So it's really about having that discipline to make sure that we've got the foundations right, which is the answer around, you know, so, you know, Howard talked earlier on about kind of, you know, finances. Yeah, it is why it's so important to get financial control. It's why it's so important to have those partnership agreements in place and so on, because otherwise the really good ideas we've got and solutions, they wither on the vine, they don't succeed in the longer term.
Yeah, noted. Thank you, Susanna. Thank you, Lisa. Now I've got two Peters next, so I'm going to go to Peter Smythe first and then Peter Cook. So, Peter.
Great, thanks. So the set of principles in the future system document make a lot of sense to me. Where it gets a bit more tricky is where you've got an environment where people are operating in contractual tram lines. They're sort of hemmed in by their contract. So my question is to the ICB, really, about can we have some granular examples of how we're going to change as a result of these principles the contracting environment? The document alludes to it. It talks about changing NHS payment mechanisms and various other bits, but that is the key, I think, to implementation, because my read of our environment currently is the contractual lines are being drawn rather harder than they have been previously on all sides. So that's a sort of challenge and a request for examples, really.
That's a good point, Peter. And I know we've got Andrew and Howard here. I don't think we're looking for examples now, Andrew and Howard, but perhaps an acknowledgement of the point and an action to take forward. Do you want to come in, Andrew?
Yeah, just it came up in a conversation this morning, Peter, I was having with Maddie and Peter Whiteman, when we came to exactly the same conclusion that actually we need to start describing how this is going to happen, particularly in primary care, and particularly with a view to working out how we work financially and contractually with primary care in a different way that supports future shift rather than expecting it to happen through goodwill. So yes, recognition of the same issue, but nothing firm to give you yet, I'm afraid.
Okay, so we'll put that onto the ICB agenda, Andrew. Yep. Agreed. Lovely. Thank you very much. Thank you, Peter. Let me go to Peter Cook now. Peter, welcome. I think you're here for Shane today, are you not?
Oh, yeah, thank you. Peter Cook, SNF, deputising for Shane Gordon. I suppose I just wanted to sprinkle some things on top of what Susanna said, just to add some kind of examples of where some of this is already happening and to show the kind of breadth of what this covers. So surely the document is the way to go, and I think everybody's kind of said that. So some examples of what we're doing already with a range of partners that all play into some of those issues we talked about earlier on in terms of productivity, prevention, inequalities, etc. So there's a bunch of things that we're doing already around artificial intelligence. I won't name the products that we're piloting or trialing because that's advertising on a live stream, but we've got AI tools at the moment looking at helping clinicians to spot fractures in ED. Which we anecdotally seems to be proving success. We are trialing an AI product to help Parkinson's patients suffering from Parkinson's manage their Parkinson's better in the community. Something similar for stroke patients and enabling our physicians to take immediate action in terms of procedures for some of our stroke patients. And we are looking at a homegrown AI tool that we're piloting in January in ophthalmology to look at how we can reduce the number of missed appointments, which again plays into that kind of productivity. Completely other end of the spectrum, and I think one of the things that Susanna's paper and partners' papers sort of show really is the kind of spectrum of things we need to do. On the other hand, nothing to do with technology. You know, we're working with employers at the moment in the care sector about how we might increase clinical capability within care settings through supporting a nursing associate apprenticeships that we are looking to pilot in September next year. So this is where kind of relationships come in, and it's very much a relationship between ourselves as a trust, employers, universities, etc. We've had a look at some of the visits that our district nurses have made to to two homes, one in Clacton and one in Jaywick, over past months. And the view is pretty much all of those appointments could have been handled by a nursing associate within the care setting, which reduced obviously the burden on our district nursing team, so they could kind of prioritise other appointments. But also there's a real prevention thing in there in terms of giving care and preventing kind of longer term kind of impacts on some of those patients. So whether that's helpful or not, I just thought it'd be useful just to give a view in terms of what this means in kind of reality. But as people have said at the start of the journey, and there's kind of a million things to do.
No, it's really useful background and update there, Peter. Thank you very much. Susanna, unless you want to comment, I'll move us on. Should we note, Peter, thank you very much. Sarah.
Yeah, so obviously I'm quite new. This is week 4 of my first meeting, so I am catching up, but it's a really good document. Everybody agrees that this is what we need to do. It's quite exciting, obviously, for me, from a public health point of view. I think the couple of things for me is we almost need, and given the financial situation that we're all in, we almost need to double run a system, because you need to be providing what we've already got and then create the new and run them together until people get used to using things in a different way. So for me, it's how do we all support you and how we all work together to create the alternative reality, I guess, to then be able to cut down on some of the things we want to do less of. And it's always the thing that's really challenging. And then I don't know if any of you will remember the Wanless report, which maybe makes me sound old. But in terms of Wanless, one of the things that made the difference was changing behaviour of the public. And therefore, the other thing we need to do is to think about how do we support the public to accept that there are alternatives to the traditional things they've always done, and that there are better ways to use our services. And both of those things I think are probably quite challenging. They doesn't mean we shouldn't do them, but it does mean that we're going to have a little bit of an uphill battle on our hands while we get the system in the right place to make this happen.
Yes, good point, Sarah, and especially your double running point. And Howard might want to comment on this, of course. But Susanna, it's always a challenge, isn't it? Because we don't. It's not an either or, is it? At times it's a both ands. But any thoughts?
So Sarah, you're so right, and that's why the 3 Horizons framework has been so useful in terms of just helping us think about, really we've got to carry on running the kind of status quo, the system as it is, and bring in the new future and innovate on top of that as well. So we've got to find something. In my wildest dreams, this is my dream at the moment, my little Christmas wish is that we submit this nationally and somebody sees it and says, this is amazing, let's give SNE an opportunity to try doing some new things. And we have got a little bit of an opportunity with that, with the general practice pilots at the moment, where we've got some investment there. But it is also that thing in we talked about in the house. I had the slide of the egg with the sticking plaster on it is a really difficult one, because we really are limited. We're up against it in terms of resources. And I think it comes down to where we make some decisions about what are we going to invest, and it's not just our money, but our time and effort in. Are we going to invest our time and effort in continuing to kind of prop up and try and get more and more out of the status quo? Or could we make some brave decisions to actually say, do you know what, we think it would be better for us to direct some resources in something which we think is more indicative of the future? So I think those are the 2 things, is how do we find the space and so on to get our heads up. We're in a difficult position, but arguably we're in a better position than lots of other integrated care systems. So I think that's our challenge really, is how can we find that? And meantime, I will keep my Christmas wish alive and hope that somebody gives us that opportunity.
Okay, thanks, Susanna. And John, I see your hand is up, but let me just hold you for a second. I'll go to Howard, in your experience, your long experience of being desirous of transformational change, what thoughts do you have around this point?
It's a huge question, isn't it, really? And really underpins and needs to underpin strategy. I think the first thing is we've got to really focus on getting our foundations in the right state. So, you know, at the moment we're spending proportionally more on the acute than even our plans suggest, and we've got to sort of somehow get that part right. So there's definitely a massive focus we need to put on in terms of our foundations. And then for me, then there's the bit around building up a better case for the evidence for the change and how we do that at scale. So this is just me talking, but you know, we tend to do things piecemeal, and somehow we need to do something, need to think more at scale, I think, and make that case for the investment as being demonstrably better value for money than continually investing in the acute sector, etc. So some of that links back to the investment that we're making in the health intelligence function, which I think really needs to help support that agenda. And then the other part, which I think is really demonstrably in place in SNE, is that sort of cultural and willingness to do it, to make those sort of changes or small changes, because not everything involves money either. So it's about how people network together and sort of do some of that change, and I think that's demonstrably a strength, I think, of this system. But yeah, so I would say from my perspective, let's ensure we've got our foundations as strong as we can possibly get them as a really good platform for developing that change, and then I think get sharper on how we are developing our cases for some of those investments that we know we all need to make, really.
Yeah, good points, and I like your point about transformational change at scale. In which case, and let me just bring in John now, because I know, John, you've got long experience of these challenges in a number of different environments as well. What are your thoughts?
Exactly, and I'll always say an aspiration. If you only set out to climb Ben Nevis, that's all you'll do. If you set out to climb Everest, even if you only get up to Camp 5, you have transcended anything that Nevis could offer. So always go for the big aspiration, but with reality and with bifocal lenses, eyes on the horizon of the strategic goal, eyes keeping downwards. There's no point trying to get to the promised land if you fall off the stepping stones across the River Jordan. And I was going to actually go back and experience, Will. Well, I had the joy of running the Lloyds TSB network when the time came to ditch the old two legacy IT systems and move to the new IT system. And we found huge resistance among our staff. And even though they could see that the new system was better, when I went to talk to them, they told me it was the fear of change. Taking that step made them reluctant to make the move. And I was just reminded of that when Sarah spoke about behavioural change among the residents for whom we're responsible, helping them have the confidence to see that the new ways will be better as opposed to sticking with the old. Yeah. And secondly, Will, just very quickly, as Susanna says, SNE are very well placed as an ICS. And so while I have to say in this meeting, work please with our other ICBs to create an Essex-wide peace, we must not, Will, allow the other ICBs to hold us back or drag us down.
Thank you, John. Thank you for that, and noted. And actually, I suppose so totally support everything you've said there. And the general point is it's the people we work for and serve who are the most important. And what we've got to do is get great outcomes for them. And that's where our focus should be. So thank you for that. And thank you all. Sarah, thank you for provoking that discussion. And I think when we try and capture that, it's all part of our culture and cultural change as well. So thank you. Zeph, I'm sorry to have held you for a little while there, but I'm going to go to you now.
Not at all. A couple of comments from me. Firstly, I wanted to compliment the team, because something that people who are new to this meeting or watching it might not see is that there are so many themes in this document which have been developed through the hard work of this integrated care partnership, through workshops, through specific initiatives, and I can see that. I can see the work from our Uncomfortable Truths, I can see the workshops we've done, and a number of initiatives reflected in this. So this is a product of a huge amount of hard work, and that shows, and I think that increases the quality and the likelihood that we'll be able to deliver its aspirations. Secondly, I wanted to support Jane and John's earlier comments about, you know, from an NHS Trust perspective across the county of Essex, working with others on this is really important, and I think having those conversations proactively should be welcomed. And then finally, and this is one of the key, you know, it's number one in the list of how we make this happen. We say co-production, and I think, you know, keeping people at the very heart of this is critical, and I think that means we've got to take a local approach on many of these initiatives, working with partners within our alliances, our voluntary faith and social partners, and I think, you know, that centrality of people, their families and their experience as what we're achieving here is crucial, and of course it aligns with the national policy agenda as well. Thank you.
Yeah, thanks, Seth. And I'm just looking for you to nod to this, hopefully. Local but joined up? Yeah.
Absolutely, yes.
Wonderful. Thank you very much. And colleagues, we're 2 or 3 minutes before we try and wrap this, so I'm going to go to Moira.
Thank you, and really welcome the conversation. I was just going to say, I think there's more we can do with some of our populations where we have kind of lifelong relationships with them. So particularly thinking about people with disabilities and young people with mental illness, that actually we have lifelong poor outcomes for some individuals, and we spend an awful lot of money actually delivering quite poor outcomes. So actually that real kind of population health management, but around a very defined cohort of people, both in terms of people we're supporting that often go in and out of hospital care or quite restrictive placements, and the opportunity to intervene differently and support younger people to prevent them ending up on that journey, is quite a defined group of people where that actually have a lot of contact, or potentially will have a lot of contact with services across health and care and housing, and actually that gives you the proof of concept, I think, much more easily. So that sort of secondary preventative piece alongside some of the primary preventative pieces is I think there's significant opportunities across the system to drive better outcomes and better value for money.
Oh, thank you very much. Well articulated, and so lots of nods around the screen as you were speaking. Caroline.
Hi, Caroline Angus, Director of the Integrated Care Academy. Really welcome the document, and I think it really aligns well with the work of the Integrated Care Academy through their enabling functions. I think from what Susanna had said earlier as well, we're thinking about innovation not just from a technology perspective, but thinking about pathways and processes, and that's really important, which does reflect through the co-production element of the document as well. I think we do have lots of great partnerships in place around that already, not least with Health Innovation East, and we can build and expand on those with our local partners. And I think the thinking about this as a continuum from research to innovation and to transformation is about getting that evidence into practice as quickly as possible. And I think that's what's been presented through that future shift. So it's great to see our research active organisations and partners around the table as well. So on that note, I'll let Vicky come in from University of Essex.
Caroline. So Vicky, over to you, final comment, and then I'll try and wrap.
Yeah, I'll be very brief and just say it's so exciting to hear, listen here about all the talk about innovations and about change, and really just wanted to reiterate that really important, obviously, that when we do change, that we measure that it's working and that it's going in the right direction. And just to say that, as universities, both us and I know the University of Suffolk, very eager to be part of that and help you with your evaluation in any way. So just remember us.
Thank you, Vicky. Much appreciated. So, colleagues, that was a really rich and powerful discussion. Thank you. And Susanna, thank you for the document and the 94 pages, which we will all read in detail, and it'll keep us busy over Christmas as well, I'm sure. But it's great to note that actually we were ahead of the game as a system vis-a-vis Darcy and indeed the Secretary of State's proposed changes to the system, but keep going because this is a journey. I think we're noting that your action plan, next steps sheet, and I will seek to when we hopefully when we go to agreement on this, we'll hopefully then agree the next steps as part of our approval. We note that it's not an action plan, but we also note that there'll be a series of events during 2025 to help us continue to socialise this future shift, to further develop it and to implement it. Assuming we approve, we'll also be asking our co-chairs to write on behalf of the ICP and with the document into the Change NHS process. We'll be looking for an easy read version and multiple easy read type accessibility improve opportunities. And if we approve it today, I think, colleagues, it's fair to say that we should accept that it might be an approval subject to typos in the 94 pages and minor adjustments before the next, if you like, formal review, simply because it's such an extensive document. There's bound to be non-substantive issues in there that could be better worded or better presented or whatever. So with that summary of actions and our discussion, are we content to approve the actions as I've presented? I think the answer is yes, and I'm not seeing any hands raised in objection. I'm seeing some thumbs up coming. No hands raised. We're taking it as approved. Thank you. And thank you, Susanna and team, for all the great work on that. And thank you, colleagues, for the rich discussion and support. So with that, it's 10:47. Let's take a break until, should we say, until 11 o'clock. We'll restart sharp at 11 o'clock, but stretch your legs, get a cup of tea, cup of coffee, cameras off, microphones off if you can, and we'll restart sharp at 11 o'clock. Thank you very, very much, everybody.
Will?
Yes, John?
Have you got a couple of minutes?
Yes, of course.
It's just no, it's fine. I mean, firstly, I will need to leave about 11:15, I'm afraid. I have a queue of people waiting to speak to me. And how can we, both SNE and HWE have their own long list of priorities, and not SNE, HWE and MSC have the long list of priorities. How could you and I work at our level, particularly you at chairs level, to get this into the ownership of Paul and Mike, if you see what I mean? You know, I could fully understand if they said, well, it's very good paper, but we've got all this to do. I just wonder how we can work with Paul and Mike to get capacity within their list of priorities and see the merit of doing this in harmony. Do you see the points I'm making?
I do indeed, John. I'm very happy to discuss with you also outside the meeting. But
yeah, that's fine. I just wanted to raise the question.
No problem. What I'll do is I'll take the immediate action to be in direct contact and send it to and discuss with Paul and Mike. But then perhaps if you and I join up outside the meeting and discuss. Yep, okay, wonderful.
Yeah, and I was very happy for anyone else to hear that, because it's in everyone's interest that we join up.
Yeah, no, totally agree, John. Thanks very much.
Thanks, Will.
Okay, thank you. Bye.
Did John? Oh.
Hello all, and thank you for that background, that backdrop screen, Susanna. It's a good one. You've been busy producing that, I can see.
Yep. Yeah, it's a good way to do it.
Yeah, wonderful. Okay, so dead on 11 o'clock, everybody. Thank you for coming back so promptly. Let's move then on to the next item, which is perspectives on the October budget, in short. What we're going to do today is try and take a system perspective, of course, because this is so important and impacts all parts of our system in so many different ways. But Susanna, I'm going to hand over to you to do a general intro and then to run the item. All yours.
So thank you. So I've just shared on the screen one page of the set of dashboards, which we're going to come to in the next agenda item, which is our set of system assurance dashboards. And this is a dashboard which is attempted to give a kind of very high level summary of kind of risks and issues across different sectors in our system. And one of the things I think that's quite striking about this is the impact of financial pressures across literally every part of the system, which I think we would all agree are probably, in the level of, the unprecedented. But also the fact that across a number of different sectors, they're then in addition impacted by some of the consequences of the recent budget. So for the paper this morning, we've got 3 different contributions, which are from the voluntary community sector, from some work the Community Action Suffolk have been doing. In actual fact, Prina's unwell. She's on the call, but she's lost her voice. So Ian Turner, who's a colleague, is going to talk through some slides from the care sector, social care sector, and then Peter Smythe from the perspective of general practice. So I think we're going to just have a sort of 5 minutes or so each, Will, and then I think it'd be useful to have a conversation about what some of the kind of impact of this is across the sector. So I think we're going to Hannah first.
Thanks, Susanna. Good morning, everybody. So in your packs, you will see that there is a letter that I wrote a fair few weeks ago now, just after the autumn statement, on behalf of 29 organisations in the voluntary sector. I don't know about others, but in my pack, there are some gaps in the letter in terms of some of the numbers and things. So I'll pick out some particularly pertinent points. But it's really important to say that this was a moment in time letter to Suffolk MPs. So it was the result of a 48-hour survey, that was all, and is written on behalf of 29 organisations of a sector that is thousands and thousands strong. So the scale of the impact is likely to be much, much higher than the letter actually reflects. And indeed, from conversations with other organisations more recently, we're already superseding many of those numbers. So just in terms of those impacts for us, it's really around, the letter is centred on the national insurance contributions. So one of the figures in there is an additional 2.33 million for those organisations. We're actually well over 3.5 million now, and I think we're going to sort of supersede 4 by the time we've come through that. We are budgeting at the moment, as some have said earlier. 14% of the respondents to the survey said that they didn't have the reserves to cover the increased cost, and 35% only have reserves to cover it for 12 months. And obviously this is going to be a year-on-year implication as we go through. You know, we have been tightening budgets and making as many cost savings as we possibly can, as everybody has over the last few years, certainly through COVID and the cost of living. So there are very little, if any, savings now to make in terms of costs within our organisations. The job losses figure in there was 85. We're well over 100 now of those potential job losses in year one. And as I say, this letter was primarily written about national insurance contributions, so it doesn't take into account additional figures around minimum wage, living wage, and, you know, little, if any, inflationary pay rise for other staff in the new financial year. Our staff operate at capacity to deliver the services in line with funding requirements. So I think that's really important to note again. And generally the consequences are things like service cuts, service closures, and we're already starting to see some charity closures nationally as a result of this before it's even actually come into play, just based on budgeting. So our ask really, important to say also that obviously national infrastructure bodies have also been lobbying on this, and we have now, some will have seen, we've had a letter now from the Chancellor to those national infrastructure bodies to say that there won't be any exemption for charities and they won't be overturning that decision. So for us, the next steps really now are to work with you all in terms of commissioners, grant makers, funders alike, and ask you to sort of consider your approaches to contracting and grants for the new year, and also currently. And specifically, I guess, for us with the Resilience Charter as well, to sort of bear that in mind and the things that we've signed up to within that around proportionality and the additionals around monitoring and requirements. In terms of current contracts, for us, many of us have current contracts that are multi-year with little or no inflation baked in, yet alone any provision for these impacts of the autumn statement. So I would fully expect, if you haven't had them already, to be getting requests from voluntary sector around reprofiling, either in terms of service reduction if there isn't any additional funding, or that additional financial ask to cover some of these costs. Some organisations are saying that they are at the point of having to consider handing contracts back, which will clearly have a huge impact on communities and families. In terms of new contracts, there needs to be some understanding that if it's the same level of budgeting, there won't be as much service on the table. For many years, 15% has been the kind of standardised figure for core cost recovery. We have been lobbying over the last year really to rise that to 20%, and we are asking for that to be a standard figure going forward. And also to really consider those inflationary rises, if nothing else, for multi-year contracts going forward as well. But full cost recovery is clearly what we need within all of our contracts. We are budgeting now. The lottery, who are a major grant maker, obviously, for our sector, have already made a statement to say that they will consider those things. They are allowing reprofiling, and some of us are doing that already. But I think also in light of the sort of previous conversation we've just had about prevention and left shift, I guess my real ask would be to consider fully what would happen if we haven't got a fully functioning voluntary sector. What would happen to that left shift, and you know, in some cases, if those services are not there, or those charities or other registered organisations just aren't there to deliver, and the impact that that will have not only on the wider system and cost to the wider system, who may have to pick up some of those people and those families, but also the impact on the communities, the families themselves, and you know, the further things that that could do in terms of the wider determinants of health. So that's it. I was given 5 minutes. I thought I'd whistle stop through it, but yeah, happy to take any questions, probably after everyone else.
Thank you, Hannah. Susanna, shall I stick with you to introduce Ian?
Should maybe run through the three and then take questions at the end, if that's okay. So yes, so Ian, because Prim's lost a voice, so Ian Turner should be on the call. And I think, Ian, I've got your slides if you'd like me to share the screen.
That's fine. Yep. Fine, Susanna. I'll prompt you to change as we go. Let me just introduce myself first. I'm co-chair of the National Care Association, but I've been a provider of nursing and residential care in Suffolk for nearly 40 years. Can we get the next slide? So Suffolk Care Association, along with the national bodies and all the other local associations, basically try and provide support to the many small and medium-sized providers that are in not just Suffolk, but across and Essex, but across across England. Next slide, please, Susanna. So the fundamental point that I want to make is not the detail in here. We're affected just the same as retailers or hospitality, but the key point for us is that this isn't the first year that we've had a major increase in costs, which fundamentally have not been fully funded. Over the last 4 to 5 years, we've seen 7 to 10% increase in our costs, particularly the national living wage. And consequently, we've had to find over the last 4 years significant either savings or additional revenue that we can find from elsewhere. Next slide, please, Susanna. So the key point here with this slide is that we are not in a position like many other services where we can increase our costs, increase our prices to cover the increase in costs. I think it's worthwhile me pointing out to members that care homes revenue is about 40% from the local authority, 40% from private funders and 20% from NHS in terms of funded nursing care or continuing health care. For home care providers, that percentage can be as high as 95% of their revenue coming from the local authority. So the local authority's ability to actually match the prices that we need to actually stay viable is absolutely fundamental. Next slide, please, Susanna. So if we look at what's actually happening, I'm not going to go through the detail in this slide. There are differences in effect on care homes and home care. Care homes are not a business that you can get into or get out of quickly, whereas home care hasn't got an asset behind it and is therefore easier to actually move in and out of as a sector. So there will be a quicker response from home care providers than there will be from care home providers. Okay, next slide, please, Susanna. Here are some of the comments and some of the things that providers have been saying to us in Suffolk, but the overall difference is that what's happening in the sector is that people are sitting back and saying we need a strategic review about whether we ought to be in this sector or not. Yeah, and that could have significant effects on the NHS's ability to actually discharge patients and keep people out of hospital in the first place. Okay, next slide. I think that the overall thing is that if you haven't already seen it in the documents that Prima supplied, the Nuffield Trust estimate that we need as a sector, home care and care homes, need some £2.8 billion to actually provide support for these changes, national insurance changes as well as the living wage changes. And I think in summary, we're basically saying that we are looking to actually, in detail, in a similar way to the NHS funding detail is due out next week. The local authority funding detail, I think, is due out at the similar sort of time. And very early in the new year, we've got to see exactly what the mismatch is and what we can actually do further to mitigate the impacts of it. Is that a reasonable 5 minutes, Susanna?
I think it's spot on 5 minutes, Ian. So if you've finished, yeah?
Yeah, happy.
Brilliant. Okay, brilliant. Thank you. So we'll move on and then we can move to questions. Will, although Nicola's got a hand up. Did you want to come in specifically on that?
That's all right. I'll come back.
You come back at the end. Is that all right? Okay. So last but not least, Peter is just going to provide a perspective from general practice.
Thanks, Susanna. So I won't take a great deal of time because I think the paper speaks to itself. But in essence, I thought I'd just run through at practice level what the budgetary changes mean. So we think with the drop in national insurance thresholds and the increased percentage payable, it will cost your average practice about £30,000 a year. But that effect is magnified considerably when you run through the minimum wage changes, because that increases your payroll by about 7 to 10% costs. So we think on average, an average Suffolk practice will be around 100,000 down as a result of these changes, which is a huge amount of money. If you add in the local pressures that we're experiencing, so for example, there is no winter pressures funding as there has been for many years previously. You add in sub-inflationary, what we call LES uplifts, which we've had year on year, and overall a percentage drop in the core ICB spend on general practice as a percentage of the whole spend. It looks kind of tricky. And then, of course, as Ian alluded to, we are also in the same position that we cannot really increase our other income streams massively. Our core business, 95% is NHS business. So we are on the same footing as the care homes and social care on that matter. And sadly, general practice carries personal liability for this, so we cannot ring fence or restrict our personal liabilities as general practice partners, which forces us to behave in different ways at times. And perhaps unsurprisingly then, that's the backdrop to the national collective action, and obviously that's occurring in Suffolk too. And I think perhaps even more worryingly and much less publicised than the collective action is the quiet quitting that's going on. That it's just so difficult that people are doing what they can but no more, and that then fails to meet the needs of our population. So having thoroughly depressed you, I thought we might end on a slight uptick. I think at our best, and we still, I think, retain largely the capability to do most of this. We're cost effective, we're high volume, we're local, we've got continuity of care. That's what we do, and that's what you're looking for in left shift. So Howard talked about shoring up the foundations, and we are, I think, a strong and big part of that foundation. If we can shore it up, we can probably do what you're after in terms of left shift and future shift. So my ask is that we're not neglected in that way, but also that the cross-subsidising effect of left shift done correctly is magnified. If we don't do it correctly, we can do something here.
To you, Chair. I think you had a question from Nicola and might have some other hands up.
Yes, thank you, Susanna. And John, I saw you put your hand up as well. So let me go to Nicola first.
Thank you so much. So, I mean, it's been really well articulated how this appears to undermine the vision around future shift, which we've talked about with such enthusiasm in this meeting. And I'm reflecting on this and the reality of the NHS being ring-fenced. And Howard, I don't know what your view is on this. I suspect that will come down to some very complicated calculation, because it may not be possible to do that from an actual national insurance contribution point of view, to actually identify, you know, all of the employees that work for the NHS apart from somewhere else. So that's slightly aside, but I suppose what I'm trying to say is that although it appears on the surface the NHS is exempt, that may be a statement that's not necessarily underwritten completely as we go forward. But that doesn't detract from the fact that, as we've articulated or heard earlier on, that we need to look at the real transfer of resource away from the acute sector, which is expensive, which the vast majority of people don't need to be in. And so I really hope that we can work collectively on this. It would be easy for something like this, which seeks to distinguish between NHS and other organisations, for that to be quite divisive. And I think the answers will only come from collective action, collective steps that we can work together and actually not necessarily always see those organisational boundaries, because that's not what our population wants to see. They don't want to see those handoffs and doors closing. They want to see actually us working together.
Yeah. Thank you, Nicola. And I saw a lot of nods as you were speaking. Susanna, just before I go to John, one of the things that's in my mind here is whether this we need a system approach to this, I think, is what people are going to be saying, whether we actually might need a face-to-face on this in January, possibly. I know that's a big ask, but I'm just wondering here whether how we will get to a system position. But I'll let you think about that. Let me bring in John and then Lisa, and then I'll let you come back. John?
I'll just record factually that I've similarly had approaches from the Essex Care Association. I've been written to by hospices and by providers of care for those with learning disabilities. And one does have to conclude, I'm not making a political point, Will. I just wonder if this was really thought through, the full implications of this, actually. Because my worry, Nicola, is this will undermine the ability for Future Shift, as organisations have to work so hard to create a response that means a reprioritisation of their own activities and resources. It actually further impedes the ability to have space for Future Shift. As has been said by the Suffolk Care Association, so much depends on the settlement that comes forward. We're expecting it next Thursday, as to how much space we have. We are going to have to work out how we both support the voluntary sector, which is desirable, but also the care sector, which effectively is statutory.
Yeah, no, thanks, John. And it was that timing that made me wonder whether January might be the, with the NHS and local authority financial positions at least being known, then we might be in a better position to discuss based on the facts. But anyway, thank you for that, John. I'm going to go to
leave now, Wilson.
Yes, no problem, John. Thank you very much. I'm going to go to Lisa, to Howard, and then Andy. Lisa?
Thanks, Will. I just wanted to, first of all, echo Hannah's points, but on behalf of the North East Essex voluntary sector, it was discussed and agreed at the Voluntary Sector Alliance that Hannah would present on behalf of the entire sector. So although obviously the data that she has is Suffolk related, we're in a very, very similar position in Essex. There are big organisations like the Essex and Herts Air Ambulance who have estimated that this will probably cost them around £100,000, but even organisations that employ just one member of staff are looking at least £800 per staff member, which is damaging to people's sustainability. I think the other point is that many voluntary organisations subsidise through their reserves or through fundraising a lot of the work that they do. So it's a real problem for us, and we're particularly concerned. But this is obviously a Suffolk and North East Essex issue, even though Hannah who presented on behalf of the voluntary sector.
Yeah, understood, Lisa. Thank you. Well articulated. Howard.
Yeah, thank you. I guess first of all, just to say thank you. That was a really clear articulation of the pressure across the various parts of the system. So and it's one that I know the ICB and definitely myself personally are really cognizant of, and quite nervous about, if I can say that, particularly pertaining to 25-26 planning. So it's going to have to be a very big area of our focus as we get into the meat of the planning, particularly once we fully understand the implications of the allocations we receive, what the guidance says that we have to deliver with that money, etc. And then just to support what Nicola said, so the NHS itself isn't exempt from these changes on employers, so we still have to pay it. There's an assumption that somehow that'll feed through in terms of our allocations, but it's not an exact science, as Nicola's just said, and we'll see. There could be a shortfall in there, but even if there isn't, even if it does match up, there's no question that a large part of the funding growth that the Chancellor announced in the autumn statement is going to go on paying for this change, and so it's either way it's going to limit our hand in terms of what we can do with our money next year. So it's going to be a really challenging year, I think, for 25-26, and we're going to have to work together to get through it hopefully in a safe way, I think, as we get into that. Thank you.
Yeah, thank you, Howard. Well said. Andy?
Thank you. I probably know the answer to this, but I need to ask it. Were we to end up balanced financially by the end of the financial year, and that's a huge ask, and we secure as a system the 30+ million bonus, is the money earmarked already, or is that up for negotiation? And similarly, is the Better Care Fund for 25-26 also already agreed, or is there some movement in that?
Okay, Howard, can I ask you to think about that? Let me and then come back with your answer. But let me go to Hannah first, and then we'll try and wrap on this one. I think Susanna, I'll come to you for the wrap, but I think it might be some January work required based on the facts as they might be in January, as people have articulated. But let me go to Hannah, and then I'll come to you. Oh, I see Moira's hands up. I'll go to Moira, then Howard, and then over to you, Susanna. So Hannah?
Yeah, I just wanted to also make the point that actually it's not just about impact on service delivery, it's also impact on ability to engage in that co-production, the consultation with communities. It's all the other stuff that goes in the background as well. So it's not just about delivering what we're asked to deliver through contracts, it's all the other thing, because when the voluntary sector are kind of, you know, every meeting costs and all of that sort of stuff as well. So it's important to recognise that, I think.
Yeah, and it'll put up all supplier costs as well in the same way. It's across the board, isn't it, Hannah? Yeah. Okay, let me go to Moira.
I was just going to feedback on that Better Care Fund question. Excuse me. So that will be linked to the information on allocations that that Howard was referencing, John was referencing. The plan's not yet agreed. We agree the plan each year. So that said, the impact of all of this will obviously play through into any decisions on the Better Care Fund. And obviously those are done jointly by the two local authorities with the ICB.
Yeah, lovely, Moira. Thanks. So it's more information to come, basically, isn't it? Let me go to Howard. Let me hold you. Let me go to Steve, and then Howard, and then we must wrap. So with you, Susanna. So Steve first.
Yeah, thanks, Will. And just very quickly, just echo what John has said. Previous years have been difficult. To express that this year is challenging is to underplay it. We will have to wait for the settlement, and as everyone has said, we will all have to work together to try and continue to deliver services. It is beyond challenging. Thank you, Will.
No, thanks, Steve. So again, you're basically saying until we know what the figure, the same as we've said already, till we know what the figures are, it's a bit of a, not hypothetical is not the right word, but we don't have all the information, do we? Right. Howard and then Susanna.
Yeah, I think, to be honest, the question's sort of been answered really, but on the incentive money, 20 million of that 30 million is capital. So I would still expect that to be invested. And the 10 million of revenue, I think it's probably safe at this point to assume that there is no free money, if you like, for next year. We really need to work through the implications. And I think Moira has articulated the position on the Better Care Fund, and that will obviously form a key part of the guidance that, you know, what growth element goes into that pot. Yeah, at this point, we just don't know.
No, okay, no, understood. Thank you. And I think we're all mutually and jointly sympathetic to each other and the positions here. Right, Susanna, what are we going to do about it?
Yeah, got to love my job sometimes. I think that Steve's point is first and foremost, which is that this is beyond challenging. I think that we need to kind of, I think it's not just challenging, it's beyond challenging. The second thing is that it's very obvious to me, listening to everybody, that there's still a number of unknowns in this. So, you know, we don't yet know what the local authority settlement is. There's also potentially, you know, some other things on the horizon, like the white paper around devolution that we're expecting anytime soon. Also, we don't know yet what might come with the kind of NHS financial allocation, and obviously, well, we're told now not to expect the new NHS plan until I'm now hearing late April. It seems to be kind of getting further and further away, but certainly that's in play as well. I think one of the things that I would like to commend the partners in the acute and community trusts in West Suffolk Trust, ESNEFT and the ICB on is the piece of work around sustainability that they're doing, which I think is really, really welcome, because obviously, as Howard said, that you know, just thinking locally, you know, getting kind of control locally increases our ability to kind of think about, well, what can we do in terms of kind of NHS budgets. So I think, Howard, that piece of work is going to start in the new year, and I know that the ICB very much welcomes sort of, you know, wider partner kind of input to this. And then I was also thinking about that we need to kind of think both nationally and locally on this. So I wondered, Will, whether alongside sending Future Shift to national colleagues, we might also just reflect back our richness of our understanding of now, okay, this is a really good vision for this, but by the way, this is what's making this really, really difficult. Because it is quite striking that when you look at Future Shift and you say, well, look, this really reflects what's coming down the line in terms of what we need to do. It is the very partners that we need to deliver a Future Shift that are impacted by a lot of this. So I think we could think about putting those two things together nationally, and then thinking locally, perhaps when there is a little bit more clarity. You know, one of the strengths of the system is getting together as a system to talk about that. So I'm actually wondering, I'm going to mention something terrible here, whether there might be a need in the new year to bring this committee together in person at some point, perhaps for an extraordinary meeting to talk about that, maybe with a focus about this around, you know, as the key enabler really around Future Shift. So those are my thoughts, that it might be an extraordinary meeting, as you say. Perhaps I think January might be a little bit early, but we could perhaps think about using the date that we've got in February for that.
Yeah. Okay. Thank you, Susanna. That sounds very sensible to me. And unless anybody comes up with a better idea, and you don't need to say now if you've got a better idea, pop an email over to Susanna if you have, or whatever better method of communication you've got. But should we take that? Should we say that we are all mutually, jointly, severally concerned about this in every respect? And at the moment we're suggesting an extraordinary meeting, probably face to face, just so that we can spend the time focused entirely on this item in the new year, date TBA. Everybody happy with that? Well, happy is not the right word, but you know what I mean. Right, just everybody happy that way forward? Wonderful. Okay, thank you all. That is very useful. Now we are a little bit behind because I let that discussion was so important. I didn't curtail it quickly. We've got 2 items left really: the ICP assurance dashboards and the uncomfortable truths. I'm going to say 15 minutes for each now, so apologies for that. If that's too tight for you, then help us move a little bit faster if you can. ICP assurance dashboards. Lisa, over to you.
Thanks, Will. Well, I'm not proposing to go through the whole dashboards because that would take forever. And as was agreed at the last time these dashboards came to the ICP committee, we did have a small group that reviewed them in advance of the main meeting. We had a really helpful discussion on the content. And as a result, there have been some of the developments that were suggested that were very quick to make have been included in them in this latest suite. But there are others that are suggested to be incorporated into the next iteration, and I've detailed them in the attached paper. So there were several key points just to draw attention to from that discussion. The first, Susanna's already sort of flashed up on the screen, was looking at having a slightly broader view around system risks. So there's some new dashboard pages included around risk. One that then sort of shows the national picture from the National Risk Register, a very broad, high-level view of system risks and issues, and then, of course, at organisational level, the assurance that's going on through the boards of the constituent organisations. So that's one of the changes. 3 points really, I think, to bring attention to from the discussion that we had. One was some concerns in the trend in hospital admissions for self-harm in younger people that was showing through the Ipswich and East Suffolk barometer measure data, that really would be worthy of some further investigation at a local level to see if this trend has continued, because the data that we had was 2021 data. That data is no longer published at such a granular level. That's now on a county level. So we can't see whether there's still that sort of that isolated trend continuing. When you look at it across Suffolk on the whole, it doesn't have the same picture, even when you look at it retrospectively. So I think being able to sort of look at some of the hospital admission data for that particular group would be really helpful. The second point to bring to light is there was one of the measures on the belonging, safety and purpose section with a trend that showed an increase in violent crime across a number of different geographies. And that would be of interest to see if that is a real increase in violent crime, or if it's artefact of how crime within that category is recorded because of process improvements. So that's another question that we'll probably take to our police and crime colleagues. The other point of note was around the inequalities dashboard, and just particularly sort of that the biggest indicator of inequality related to that was the standardised admission ratio for chronic obstructive pulmonary disease. I have put a little bit of detail in the paper what some of the underlying causes of that are. So they were really the key points to draw attention to, and potentially get some feedback from partners on and do some further work on. The second part of the paper that I'd just like to draw attention to is that we've included the second Anchors Impact Report, which is a supplement to the sort of the dashboards that come under AIM 4 of the fourth purposes of the ICS. And this particular impact report focuses on estates and sustainability pillars. And we've been producing these impact reports as we did with the employment one in the previous iteration, because we really didn't want to lose the richness of the information and the volume of work and the initiatives from partner organisations. And members of the Anchors Board have placed a really high value on sharing and learning from each other. So this is it's a supplementary thing. The dashboards are very much a snapshot, but this gives a lot more information. It includes case studies and much richer picture of the information. The next one we produce will be focused on our role as purchasers and procurers of goods and services, and in how we support communities. So that way we'll have a whole suite of the dashboards and of the impact reports across the financial year. So they were really the key points I wanted to add. I will ask Lisa if there's anything that she wants to add to that. And unfortunately, Hazel Roberts from the CQC couldn't be with us today, but she did email in advance to say that what she would have said should she have been here is that she feels it's a really great starting point for the conversations about health and care and social care inequalities across our patch, that the data and key risks being highlighted enable rich conversations to be based on insight and intelligence, and hopefully they'll assist us to look across care pathways for people in the area to tackle the gaps and challenges faced by our local population. We recognise, though, there is a lot more to be done. We would welcome any sort of further feedback on the dashboards and how they can be further developed and improved. And certainly from a CQC perspective, while the ratings, because there are dashboards that include the ratings there that are included, one of the developments that we're suggesting is to look at sort of what the trend in those has been. So that's pretty well all I wanted to say. I don't know if you wanted to say anything, Lisa, or...
I was just going to thank you, Liesl, and just to support what Liesl said, Hazel from the CQC thinks that this is, you know, an extraordinary piece of work and is really massively new in the way that systems are looking at data together across organisations and the NHS and care and partners. I think the dashboard will be forever in development. It will always be developing because it's one of those things. It's an extraordinary thing to bring a system dashboard together. I know how difficult it is just to do an organisational dashboard. So we're incredibly grateful to Liesl for leading on this, and I think it really helps to kind of bring a transparency of data to us, which will help us to kind of look at key lines of inquiry that we want to look at to further understand. It will help us to think about actually what patients, what public members do we want to case track, what intelligence do we need to understand that data a little better. And I think the other conversation that we had, because we had Anna Crisp with us, was about it's quite health focused at the moment, and how do we make sure that it really represents the system. So yeah, thank you, Liesl.
Thank you, Liesl, and thank you, Lisa, for that. And also, Susanna, thanks for that note from Hazel. Really good. I as you know, I love numbers, so I like this report a lot. And thank you, Liesl and team, for a fantastic piece of work. A couple of thoughts. I mean, I think there were a lot of nods and smiles around the table as you were both speaking. I think we're basically saying that we like what is there at the moment. We recognise it's a journey, and that it might never be complete, might it? Because this needs to keep being iterated. We'd very much like to see the trends analysis, I think, in due course, as you mentioned. So let's take that as agreed as well, unless anybody objects. Lisa or Lisa. Lisa, you mentioned the taking the issue to police colleagues that you raised. Is there also a possibility that there might be some HOSC interest in this information? Do you think that we could promote? What do you think?
I think there's every potential for it, and I'd be more than happy to do that. I think also recognising that health and wellbeing boards pick up on that sort of that wider view as well. I think there's also some cross discussion potential to have there.
Well, again, without going into the detail now, would colleagues be happy if we summarised, if we said in summary that we suspect there are other system players and stakeholders who definitely will be interested in this, and that we ask our secretariat colleagues to take that forward with appropriate stakeholders in an appropriate way? Would that be helpful? Yeah. Happy? Lisa, yeah, come in.
And I guess the other thing as it develops, obviously reflecting on all of the discussions that have been had this morning, is how do we use it to understand impact of future shift and impact of kind of financial austerity, and what metrics specifically will we be looking at to understand that? Because I think it could be used understand the impact across health and care.
No, that's a good point, Lisa. And actually, I wish I'd said that now, because, you know, one of the most common things you hear me say is data is useful, but what we want is information, don't we? We've got to use it. Yeah, good point, good point. Susanna, I'll come to you to wrap on this one.
Completely agree, no data without a story. And what's really interesting is we're at the very beginnings of being able to triangulate data and information and evidence from different parts of the system, where we might be looking from one lens, from one perspective, but actually we might understand something in a better way by bringing some of that together. I've been involved with kind of building systems for some time, as people know, and one of the things that people often ask is, how do you know the system's sort of working? What benefits are going to be, what outcomes are different, and so on. And you can just see how complex the answer to that really is. And also you can start to see where there's gaps in terms of what we measure. Anna Crisp and I can entertain each other for hours about, how little we actually know and where we haven't really measured the right things. So I think some of those ideas are really good ones, Will. And, I see Steve on the call. I think other elected members, that's the sort of question we often get asked. How do you know any of this is making a difference, kind of thing? So I think it would be worth sharing this in other forums, but I think with some explanation would be really, really helpful as well. So I wouldn't certainly like to go out without certainly Liesl and if possible Anna and other people kind of around, but to have that conversation so that we can all get around and own some of the challenges that we face at the moment.
Okay, thank you, Susanna, for that. So let's take that as empowering, authorising, supporting our ICP Secretariat team to take this out into the wider system, continue the development, continue the journey. And we look forward to the next report, which will include, I suppose, Lisa, what we're basically saying is the social value impact as well, and in the next one.
Yeah, I think in the paper I've detailed several developments that will be included in the next one, but I think we'll keep adding to that list.
Wonderful. Okay, thank you all, and thank you for being prompt with that one. Really helpful. I'm then going to move us on to the final item today, the uncomfortable truth self-assessments. Sharon, I'm coming to you for this.
Thank you. Yes, it's me and Fan Wilson, but I'll just briefly give an overview. So just to remind everybody, and I know there's quite a few deputies here today, and many of them were involved directly, which is great in all of this. So the background is that we held 3 events to explore the issues of entrenched social injustice that contributes to inequity within society, but also particularly health inequalities, which just reflect what's in society, focusing on why they persist, how we should approach things differently, because what we're doing now doesn't work, and then what more we can do. And we arrived at the end of that at 22 actions that we can all take as individuals, teams, organisations, and as a system to achieve safe, integrated, equitable and compassionate services, designing and delivering them, to create fair and inclusive workplaces for everyone in health and care, and to continuously learn and improve. So they were our 3 focuses around, and those 22 actions come within that. We had actions for individuals, so we want individuals to be curious, to show allyship, to be trauma informed. As teams, we want safe workplaces to be created, and that's physically, psychologically, culturally, sexually safe, and to have reasonable adjustments for those who need them. As organisations, we want partners to co-produce and co-deliver, to be inclusive and collaborative, to collect and analyse the right data. And as a systems across partners, we want to share records for the benefits of those we serve. We want to learn together, and we want to collectively assure what we do as well. So the report you have in your papers shows that there is great progress in the commissioners, providers, local authorities and voluntary and community sector as well. And just to note that Suffolk County Council was keen to contribute to this, but is just waiting until their reorganisation is complete, so that they'll be in the next iteration of this. And there are examples of great progress, I think. So in no particular order, as they say, there is a lot of thinking about inequality, where it comes from and what best practice is. People are developing and starting to implement plans and to start seeing the results of those plans. We're using our power as anchor organisations, as just discussed, but we have that power to influence what goes on in our systems, our society, and the wider society. We see that trauma-informed practice is being looked at, is being implemented, and we are starting to create workplaces where people can thrive. All of what we've learned in Uncomfortable Truths in Future Shift, and I'm really pleased Zephan referred to that earlier, that he could see that, so grateful for that. We want to embed our learning from Uncomfortable Truths and those actions into assurance, and we want to report regularly. I've suggested biannually, every 6 months, but that's open. I appreciate there's a lot of pressure on people, but we want to continue that pressure of showing and holding each other and ourselves accountable. We want to encourage incorporating these actions into commissioning, into contracting, and into monitoring performance as well. And most importantly, we want those conversations to continue and to push further and faster, probably with further events, but we want to show what we are doing and where we're going. But I'm going to pass on to Fanwell now as well.
Okay. Thank you, Sharon, for taking us through that paper, and also thank you for pulling all that together. If I can just sort of point out a few things, Chair. I'm really glad that we've put this paper at the end of the meeting today, because if we reflect on some of the discussions we've had, we've talked about the future shift, which I think there's consensus in the room that this is the direction of travel. That's where we need to go. And I think Susanna has talked about, that being the extension of our ICS strategy. But we've also talked about some of the challenges, particularly financial challenges that we all face with the budget and all those things. And sort of pulling all that together, I think it's pretty clear that we are going to have to do things differently. We need to, think smarter, do smarter things. There's a saying that Susanna loves, saying most of the times, which is, culture eats strategy for breakfast. Now, we've got a strategy, we've got all these plans in place, and we know that, we want to move towards the future shift. But if we don't have the right culture in the system, we're never going to achieve any of those things. Now, these 22 actions are setting in place the right culture for us, within the system, to allow us to, start to deliver some of those things, particularly with all the challenges that we're facing. So I'm really pleased that, as Sharon has just mentioned, that right across the system, people are really committed, to delivering this. Yes, there's still, quite a lot to be done. We do have a lot of plans in place, as it reflected in that report. But my ask to everyone is really, if, particularly those who are on AMBER and sort of looking at those plans, we need to step that up and start to implement, some of those plans. And those who are, who have started delivering, some who are on green, it's then how do we sustain some of that work that is that has been, started. Within the People and Communities Committee, we've also set up an insight and oversight group that can support the system, because it's comprised of, partners and people with lived experience of some of these things. So we can support partners who might be struggling in terms of, what is it that we need to do to deliver that. So, the People and Communities Committee is here to support, yes, also provide some constructive challenge as well. But please do reach out, and we want to continue to move and drive, this agenda, because if we get this right, if we get things right by, those people experiencing inequalities, then we are likely to get it right for everyone. So thank you very much for everyone who's contributing to this, and we look forward to continuing to work with you and bring further iterations of this work to future meetings. So thank you, Chair.
Thank you, Fanuel, and thank you, Sharon. Really helpful and great piece of work. And as you say, a continuing journey based on and working with, and the foundation stone being the great culture that you guys and the whole system have got. Fanuel, Sharon, I saw a suggestion earlier. We talked about on the financial sustainability pressures issue. We talked about maybe having Susanna's word was an extraordinary meeting. Might that be an uncomfortable truths meeting as well? Is this could we combine the two? I don't want to suggest we do something that dilutes impact, but I'm just wondering if there might be added value in that. What do you think?
I think that is a very good idea, Chair, and I think we'll sit down with colleagues and consider that. I mean, it's also been suggested in the chat. I would agree that this is probably the direction of travel, but we'll take that away as an action.
Yeah, I see you nodding as well, Sharon. So we'll leave you guys to think about that and I know you'll get the mechanism right. So thank you very much. I don't see any other hands raised. I think we're all very grateful for this piece of work and supportive of the progress. We look forward to meeting again to discuss. But if I could summarise, I think what Sharon and Fanuel are basically asking for, and I realise I'm doing this in very short order, and you said much more and there's more in the paper, but basically we've got to embed this in the work of all our stakeholders and partners within the system going forward. And make sure that we continue that journey with these issues and thought process embedded in everything we do. Is that a fair summary? And I'm sorry it's so short. Are you happy? Yeah. Okay. Wonderful. Well, with that, I think we'll take it that we've noted and discussed, and we ask the Secretariat with colleagues to take forward that next step in the way that I articulated. Lovely. Is there any other business? None has been notified to me prior, so I'll just wait and see if any hands come up. I don't see any, so we'll take it as no other business. Michelle, are there any questions from members of the public that have been raised through the live streaming?
No, none will.
Wonderful. In which case, I'm going to draw it to a close 5 minutes early. Thank you very much all for a great meeting, great discussion. The next meeting, the next formal meeting. Oh, Susanna.
Friday the 14th of February, Valentine's Day. So we can move from Christmas jumpers to hearts.
Right, okay. Yeah, we might not go there the whole way. Yes, thank you, Susanna. Next meeting is the 14th of February, and Steve, you're chairing, so look forward to that. Thank you very much. And shall we say Merry Christmas? It's a little bit early, isn't it? And there's a lot of pressures on, and I know you're under huge pressures, but Merry Christmas. Have a good break. Get some downtime if you can over the Christmas New Year period. Next year is going to be as tough or tougher than this year, but you can do it, we can do it, and we will do it. Thank you very much, everybody. Great meeting. Thank you.
Thanks all.
Thank you.
So
You need to stay on. Do you need me to stay on, or you?
Oh, Sarah, I can give Will a ring. Have we stopped the live stream?
Have we stopped the live stream, Michelle?
Yeah, I just have to watch it on this screen that I've got in front of me until it ends, but it won't record this, so don't worry.
Okay, lovely. Okay, you're welcome to stay, Sharon. Yeah, no, we don't have any secrets, do we?
Well chaired, Will. I can't believe you managed to learn that on time.